The broadcast is now starting. All attendees are in listen-only mode.
Welcome to this presentation titled Taste Alterations and Their Implications in Cancer Care. My name is Bethany Hopkins. I'm a Medical Affairs Manager with Nestle Health Science Canada, and I'll be the facilitator for the session today. Taste alterations are common among cancer patients and can interfere with adequate nutrition intake, and they can also have an impact on an individual's quality of life as well as social enjoyment of eating. It's my pleasure to introduce our speaker today, Dr. Wendy Wismer, who will walk us through this phenomena of taste alterations and the implications to consider when working with individuals who have cancer. Wendy Wismer is an associate professor in the Department of Agricultural, Food, and Nutritional Science at the University of Alberta. She's a food scientist with experience and expertise in sensory and consumer science. Her research program characterizes taste and smell alterations among cancer patients and their impact on food choice, nutritional status, quality of life, and clinical outcomes. Dr. Wismer is passionate about improving the food-related quality of life of patients through pragmatic interventions and support tailored to their unique taste and smell perceptions. So with that said, I'll turn the floor over to you, Dr. Wismer.
Thank you very much for that introduction, Bethany. All right, let's have a look at the slide, shall we? Taste alterations and their impacts in cancer care. A good starting point for this discussion is the recognition of the contribution of a healthy sense of taste and smell to both dietary intake and to food enjoyment. A healthy sense of taste and smell stimulates our appetite. It influences our food choice and our dietary intake and our subsequent nutritional status. And because we enjoy the sensory attributes of a diversity of food products, healthy taste and smell contribute to our enjoyment of food and food-related quality of life. However, among patients with cancer, changes to their sense of taste and smell, so taste and smell alterations, negatively impact food intake and enjoyment. In today's webinar, we'll look at the incidence and complexities of taste alterations among cancer patients, describe their impact on patient appetite, nutrient intake, and quality of life, identify some approaches to their prevention and treatment, and also future directions in taste alteration research and management. Let's look first at the incidence and complexities of these taste alterations, including their development, duration, and recovery, and also the pathophysiology and possible mechanisms of their development. Throughout this presentation, I will abbreviate taste and smell alterations or taste alterations as TSAs, chemotherapy as CT, and radiotherapy as RT. When we look at information about the incidence of taste alterations by treatment, we can see that about half, or 50 to 61% of patients treated only with chemotherapy experience taste alterations. But this increases to about 66% of patients when treated only with RT, and when chemotherapy and radiotherapy are combined, this increases to about 75%, or 3/4 of all patients with these treatments. And we do observe post-treatment taste and smell alterations. So one such statistic is that 15% of radiotherapy treated patients experience taste and smell alterations post-treatment. Taste and smell alterations are one of many symptoms experienced by cancer patients that we call nutrition impact symptoms that all interact and they reduce appetite, nutritional status, and quality of life for patients with cancer. So other symptoms would be anorexia, pain, nausea, vomiting, diarrhea, early satiety, mucositis, xerostomia, fatigue, and depression. And they all interact and can make eating a meal seem like a real challenge, just like the giant hamburger on the right-hand side of the screen. And consequently, that impacts nutritional status and quality of life for patients with cancer. Here's some information that just shows that a multitude of symptoms are present and that they increase generally in severity over treatment. So in this table, we have the percent of patients reporting symptom present at each of the study time points, which are the initiation of the first cycle of chemotherapy, the end of the first cycle, and the end of the second cycle. And you can see that even at the initiation of chemotherapy, symptoms are present. They have increased quite dramatically by the end of the first cycle, and they either continue to increase or plateau towards the end of the second cycle of chemotherapy. So we have this complex of symptoms that are changing in their intensity and severity for each patient. A little bit more information about their persistence post-treatment. When we look at advanced cancer patients, which are those patients who are no longer receiving treatment for curative intent, we see that reports vary from just a few to 59% to 86% of patients reporting taste alterations post-therapy. And even at this time, although the patient is no longer receiving treatment, these taste alterations can be quite distressing and still interfere with dietary intake. Over on the right here, we have some information about the presence and severity of taste alterations among patients being treated for head and neck cancer. And this is on the y-axis, we have numbers that represent the intensity and complexity of the taste and smell alterations. And we see on the bottom that at baseline, at the initiation of therapy, taste and smell alterations have already been identified as present among the patients. At the end of treatment or post-treatment, we see that there has been a very large, a substantial increase in the number and severity of those taste and smell alterations. And that even for 10 weeks or 2.5 months post-treatment, at 2.5 months follow-up, we find that patients continue to experience taste and smell alterations. And although they are less than they were at the end of treatment, they have not returned to pre-treatment levels. There are a variety of suggestions to the possible mechanisms of taste alterations among patients with cancer. Because it's been noted that taste alterations appear prior to treatment, there are suggestions that it is the cancer itself that is causing some of the taste changes. And there has also been recent documentation to indicate that cancer-associated inflammation is associated with taste alterations. We know that treatment influences taste alterations, so radiotherapy and chemotherapy, largely because of damage to our taste bud cells. Taste bud cells are epithelial cells that rejuvenate or regenerate every 10 to 14 days in a healthy individual. But it's indicated that with radiotherapy and chemotherapy, that regeneration either does not occur or is altered in some way, or may become inconsistent in its timing, resulting in taste alterations. We have mentioned that symptoms impact taste alterations, some more than others. So for example, having a dry mouth, having dry xerostomia will influence the ability of basic tastants to reach or access the taste buds. And additionally, there are also some suggestions that changes to the metabolism of the patient, such as carbohydrate and lipid metabolism and protein metabolism, may also influence taste alterations. What about the impact of taste and smell alterations on patient appetite, nutrient intake, and quality of life? Well, we've identified that there are a variety of challenges, all ongoing, that are impacting the eating experience. So the taste and smell perception has changed. We have symptoms that interfere with eating as well. These combined will all restrict food choice at a point when a patient may have higher nutritional needs because of the cancer itself, the treatment, and also the modification of food choice. So all in all, the eating experience for a patient is very, very different than it was pre-treatment. What's the nature of taste alterations experienced by cancer patients? Oftentimes, individuals expect that they'll experience a taste loss, such as would be experienced by older adults. However, a taste alteration among cancer patients can be varied in its characterization. So taste and smell alterations can represent stronger sensations, weaker sensations, or in fact, no change in some sensations when we look at the perceived intensity of sweet, sour, salty, and bitter, our 4 basic tastes, and our sense of smell. And this really changes with the individual. So in this example here, we have an individual who reported that their sense of salt and bitter was as strong or not different from prior to therapy, but that their sense of sweet and smell was actually heightened or stronger, while their perception of sour was weaker. And we have noticed that these changes change over the course of therapy. And that has some real challenges for management because suggestions for management at one point might need to be altered later on during therapy. Additionally, some patients identify taste changes as being persistent metallic or bitter taste in the mouth, and those would have to be managed in addition to the stronger or weaker perception. All in all, then, eating is an experience in which the taste of the food really resembles listening to a symphony where the music is out of key. You recognize the music or you recognize the food, but now that listening or that eating experience is quite different. And as a result, with foods smelling and tasting differently from usual, there are some repercussions. So favorite foods are liked less or disliked, and that often leaves a hole in the patient's food choice inventory. And additionally, new favorite foods may be consumed. Having new favorite foods can be desirable. It's really good when patients find something that they can enjoy and works around their symptoms, but there may be challenges when these foods are consumed and they are not nutrient dense. So the implications of these changes are negative consequences to energy and protein intakes and also quality of life and also weight loss. When we look at energy intake and protein intake normalized per kilogram body weight per day, we find that there is a significant decrease or lower intake of energy and protein among patients with severe taste and smell alterations compared to those who report insignificant or mild alterations. And we can see from these values, 19.3 kilocalories of energy per kilogram body weight per day, that intakes are below recommended guidelines of 25 to 30 kilocalories of energy. And the same is true for protein. 0.7 grams of protein per kilogram body weight is less than the recommended 1 or 1.2 grams. Additionally, we see that weight loss over the past 6 months is much greater with the severity of taste and smell alterations, and that the quality of life has declined as well. We also see a change in the dietary pattern. So with an increasing severity and number of taste and smell alterations, patients typically move from the foods that they usually consume, such as a very traditional diet, say in this case meat and potatoes, through some changes, some workaround type of foods. So in this particular case, fruit and white bread. And when there are many and severe taste and smell alterations, those that are bland or light and supplements. So not only do we see dietary consequences, but also changes in food-related activities. So the results of this particular survey from Ray Walt in 2009 indicated that over half of all patients experienced changes to their grocery shopping, making meals, eating meals, also spending leisure time with family and going to social events. And a survey among French patients indicated that 75% of them experienced post-treatment fatigue that limited food preparation. So we see a real ability or lack of ability of patients who are experiencing symptoms such as taste and smell alterations to provide independently support around shopping and making and eating meals that will satisfy their altered taste preferences. Additionally, we had mentioned that there are implications for food enjoyment and the social enjoyment of food. Some quotes from some of our patients include, "It was just texture, that's all. No taste, just absolutely bland. A raspberry would be like chewing on paper with seeds. That was terribly, absolutely awful." So clearly a loss in the enjoyment of the taste of foods. Another patient said, "We went to a gathering last night to see all the food on the table. It looks so lovely, but I know I can't enjoy it. Food is social, so that's what I miss, is the social aspect of food and drink." And these are things that we take for granted, but can be very distressing for cancer patients. Let's look now at some of the approaches to taste and smell alteration prevention, treatment, and management. And sadly, there are very few interventions for prevention and treatment of taste alterations. And that is one of the things that is different about this symptom compared to pain, diarrhea, constipation, where we do have some interventions that can be presented. I think key first to managing taste and smell alterations is identifying that they are present. In the research, we see quite extensive use of clinical assessment tools. So you see on the left here a scratch and smell kit for smell identification, the use of solutions to determine basic taste identification and thresholds. And those are very, very useful for describing perception relative to normal values of the healthy population. And their focus usually is on loss of perception. However, in working with patients with cancer, it seems that self-assessment tools are most appropriate. And one of the things we've noticed in our research is that the phrasing around that taste question really influences whether or not a taste change is identified. So with our research, we have asked patients, have you noticed that your sense of taste or your sense of smell has changed? And patients who answer no will often answer yes to the question when it's phrased as, have you ever noticed that a food tastes different than it used to, or that a food smells different? So clearly the way that the taste changes are being acknowledged is not around perception of self-assessment, but rather around a perception of the food tasting differently. There have been a couple of reviews written in the past 10 years that describe interventions for the treatment of taste and smell alterations. And unfortunately, they have concluded that there really is nothing where there is a high level of evidence to support its use. I think the most popular has been zinc supplementation to either prevent or treat taste and smell alterations. But here the results really are conflicting. And that might be because of the use of different doses and endpoint measurements. And then there have been a variety of trials, some of these studies representing just one trial, some more, where a variety of different compounds have been evaluated, including THC to see if food is enjoyed more, the presence of artificial saliva to make sure that those tastings are delivered to the tongue, and also evaluation of taste change suggestion sheets. Taste change suggestion sheets, or these general tip sheets, are available at most clinics and often are not unique to the cancer setting, but are meant to support individuals who experience taste alterations associated with a variety of acute or chronic conditions. And as the taste changes are so unique to the individual, there's a lot of opportunity then, or a lot of need for an individual supporting the patient to try and identify the patient experienced taste changes and align them with the tips that are going to be most helpful to the patient. When we look at some suggestions elicited from patients in a study by Ray Walt, we find that there are a variety of strategies that were used, some which seem to contradict each other. So some patients, for example, benefited from choosing more bland foods, boiled foods, and avoiding foods with strong smells, while other patients benefited from the addition of more condiments, using more salt, marinating meat. So clearly we have different perceptions around having less or flavor or more bland foods and adding flavor to foods. Certainly assuring patients that changes to taste are not unusual is very important. It seems that it's something that a lot of patients have heard and will often ask to confirm that that is true. And I think also emphasizing that the taste change experience is going to be unique. Something we've observed that is beneficial as well is what I would call supportive food networking, in which patients share their experience with taste and smell alteration management and food choices and how they themselves worked around it. Snacks being promoted as a good way to increase intake and accommodate changes in sensory perception and preferences. And certainly because these preferences change throughout a day and over the days for a patient, a snack does provide the opportunity to present foods that are solid or liquid, sweet or savory, etc. And they are, among many patients, a good way to increase caloric intake, although sometimes a patient will consume snacks to the detriment of their intake at meals. Certainly a focus on the visual aspect of food is desirable. We eat with our eyes. The eyes are the gatekeeper to the mouth. And looking at a food that is very attractive can certainly stimulate the appetite and encourage at least a few bites, if not consumption of the whole food product. Future research directions in this area would be to identify the causes of taste and smell alterations. We really don't know definitively what the causes are or the principal cause, or the rate and the characteristics of their development and also recovery. And once we know more about the causes of taste and smell alterations, I think we would be better able to provide remedies and support for them. In addition, it would be valuable to understand why there is such individual variation in the taste alteration experience. Is there a genetic predisposition for individuals to develop taste alterations? And are those perhaps exacerbated by previous diet and lifestyle factors such as micronutrient deficiencies or smoking? Additionally, while we're figuring these things out, I think product development tailored to food preferences and the symptom experience of patients with cancer is really beneficial. So to develop fortified snacks and meal products that align with flavor and texture preferences would be a real advantage. And using the processes that are normally used for food product development in the food industry, in which the target audience, in this case the cancer patient, is asked for input early on in the process, identifying not only the sensory attributes of the product that are desirable, but also other elements of the food product that would be desirable, such as resealable packages, etc. So my take-home messages are that taste and smell alterations are nutrition impact symptoms among cancer patients, and they interfere with appropriate and adequate dietary intake, so have real nutritional consequences, but they also reduce the quality of life and the social enjoyment of foods. A real challenge to their management is that they are unique to the patient and they change during and after therapy, which suggests that individual or customized support is really important to help patients manage their food intake around taste alterations and other symptoms. And unfortunately, as yet, there are no remedies for taste and smell alterations and very limited supports. So really, it is about supporting patients with things such as taste change suggestion sheets. These are the references that I've used to support my presentation. You may be interested in those at some point, and I'm happy to answer questions. You can always contact me by email.
Wonderful. Thank you so much, Dr. Wismer, for this presentation. It was really interesting to learn about the complexities with taste alterations in individuals with cancer and some of the considerations that we need to be thinking about to individualize our approach. I particularly liked your analogy of the taste changes that someone experiences, like, listening to a symphony that's, out of key. I think that puts it in perspective really nicely. Before we close and you open the door for questions, there are a few questions that do commonly come up. And as you mentioned, this is a field that we're just really starting to learn more and more about. But I'd like you to just address a couple of these questions if you don't mind.
Sure.
The first is, you mentioned that taste changes don't always recover once the treatment is finished. And is support for post-treatment taste alterations similar to the way people would be managed if they had taste alterations during their treatment?
I would say yes, because these taste alterations are still distressing to the patient and they still interfere with food choice and intake and prognosis. So I think it's important to work with the patient when treatment is finished and identify the nature of the taste alterations and provide support for those specific alterations.
Okay, thank you. The next question we have here is, it's been reported that there are certain foods that some people say are universally disliked by certain patients with cancer. And these may be things like coffee, chocolate, and meat. And we know that there are flavor options in terms of the oral nutrition supplement world that frequently include flavors like chocolate, coffee, and mocha. Why do you think this is?
That's a very interesting point, because I've noticed also that patients will tend to gravitate towards some of those iced coffee beverages. And yet at the same time, you do see reports in the literature of patients indicating that coffee is just not something that they want to consume. So I think there's a couple things. One perhaps is that coffee is hot and very bitter, and maybe that's not palatable, but yet a coffee flavor that is served cold in a milky drink with a little bit of sweetness to it could be very popular. There may also be some other things that would be interesting to address, such as, coffee seems to be a fuel on which society runs, and perhaps even when an individual is ill, they would like to have that sensation of having had a coffee, which might be that coffee flavored beverage. But so I think that the presentation of the coffee flavor and maybe other unexpressed needs might be instrumental there.
Yeah, interesting how just having something that's perceived to be something that you'd normally enjoy, or even adjusting the temperature, as you've said, can make a difference. And then you made some comments earlier about if products are designed specifically for individuals with cancer, part of that product development is, involving those individuals and, having them be part of the process to come up with something that they would find works.
Absolutely. I think that's key.
Yes. So the last question I have here on the list is related to taste changes that may be experienced by individuals who aren't consuming solid foods. Do people, for instance, who are being tube fed, do they also experience taste changes? And what do we need to think about for those particular individuals?
It's surprising, but yes, patients who are being tube fed do indicate that they experience taste alterations and that they are troubling symptoms. And they would benefit from maybe oral support while they're not consuming solid foods, but also some support, because if we expect at some point that they're going to shift from that tube feed and return to solid foods, there has to be some motivation for doing that. At some point, foods need to taste good in order to be consumed. So absolutely, whether solid foods are regularly consumed or not, there needs to be some management of taste alterations.
Yeah, it's interesting because when people aren't eating and drinking by mouth, that part may not, the oral care and paying attention to sort of keeping that area as healthy as possible may be overlooked, because of everything else that's happening and the fact that they aren't actually consuming anything by mouth currently. So it's an important point to keep in mind.
Yeah.
Well, on that note, we'll conclude this presentation today, and I'd like to thank you again, Dr. Wismer, for joining us and sharing your experience with taste alterations in individuals who have cancer.
Well, thank you very much for the opportunity to speak about something about which I'm so passionate. Greatly appreciate it.